I was asked to discuss TB management among patients with HIV. So these are my objectives for this talk. As you all know, TB is a very important infection that we encounter among patients with HIV. And what is important to remember is that patients with HIV are 18 times more likely to develop active tuberculosis. So yun nga yung na-interview ni Alan, parang they're aware na the most common opportunistic infection among patients with HIV is still tuberculosis. So TB also remains to be the leading cause of death among people with HIV. And if a patient with HIV gets tuberculosis, even during treatment, there's still a high likelihood for dying. So it's very important that they should be treated immediately. Gaya nga na sinabi ng mga na-interview din ni Alan, So ano yung mga interventions to improve TB treatment outcomes among our patients with HIV? It's very important that they should have early access to antiretroviral treatment. They should have access to high-quality TB screening and, of course, TB treatment and expanded use of TB preventive treatment. So these are for individuals who do not exhibit signs and symptoms of tuberculosis. So we can actually provide TB preventive treatment. Okay, so I am sharing with you the data that I read sa Philippines National TB Report last 2021. So it is best practice to screen all our HIV patients for TB, and to screen TB patients for HIV. So the Department of Health already developed processes for these screening procedures to be implemented in our facilities, whether public or private. So the middle figure on the slides, on my slide, shows the HIV testing rate among TB patients in the different regions in the Philippines. For 2019, yun yung pink dots, and for 2020, yun yung red dots. So the national testing rate was around, you can see here, that's the national testing rate, around 35%. But the testing rate actually varies, depending on the region. The highest testing rate is in the National Capital Region, and it actually reached around 70% in 2020. But there are still regions that are lagging behind, and most regions are actually below the target of 35% testing target that was set by the Department of Health. Now, the graph here on the right shows the analysis of case fatality for new and relapsed TB patients by HIV status in the country. So patients with HIV positive status have higher case fatality rate as compared to HIV negative TB patients. And if you compare TB patients with a known HIV status, the case fatality rate is also higher, if you compare them to those with HIV negative status. Okay, so that's actually important to remember, the case fatality rate, even in our country, it's very obvious that if a patient with TB has HIV, the death rate is higher. Okay, so from the poll, you mentioned that almost 100% see patients with tuberculosis. And more than 50% actually responded that you are already confident in treating patients with TB. So we are all familiar that TB or tuberculosis is caused by Mycobacterium tuberculosis. Yan yung bacteria, yung mikrobyo. It usually affects the lungs, but it can also affect other organs in our body. So what happens, the TB bacilli is usually, we get it this way, we inhale it from the air, it usually infects the lungs. Now the TB bacilli deposit in the very, very small areas of the lungs called the alveoli. So majority of the individuals with normal immune function can stop the proliferation of M. tuberculosis, and they can contain the bacilli in granulomas. However, there are individuals with weaker immune systems, such as HIV patients, and they are unable to contain the infection in these granulomas. So there's a breakdown of the granuloma containing the bacilli, and the bacilli now escape. They spread to other parts of the body outside the lungs, and that causes dissemination. So HIV-infected persons develop TB disease rapidly after becoming infected with tuberculosis. So up to 50% develop TB in the first 2 years after infection. HIV-infected persons with latent TB infection will develop TB disease at an approximate rate of 5 to 10% per year. And that's actually higher compared to the general population. Okay? So we know that there are different kinds of tuberculosis, but the two main categories are pulmonary TB or PTB, and the second category is extrapulmonary TB or EPTB. So pulmonary TB primarily involves the lungs, and extrapulmonary TB these cases have TB in other organs other than lungs. And any other organ can actually be infected with TB. So the proportion of extrapulmonary TB among all TB cases in patients with HIV is actually high. It's around 50%. And that's also higher compared to the general population. So I just need to inform the group na in the National TB Program or DOH reporting procedure, a patient with both pulmonary and extrapulmonary TB are reported as case of pulmonary TB. So that's for reporting purposes. Okay. So I mentioned earlier that TB is very common. Extrapulmonary TB is very common among patients with HIV. And ito yung difference. Kung 15 to 20% sa all TB patients, sa HIV, 50%. So mas mataas talaga ang extrapulmonary sa HIV-infected population. Okay. So ito, I'm sharing with you a review of extrapulmonary TB cases in our hospital. So I practice at Makati Medical Center. So it's a tertiary hospital. And we see inpatient and, of course, outpatient cases. We also see HIV patients. But this review is for all cases. We actually don't know the status, the HIV status of the patients included in this review. So based on 273 charts reviewed of EPTB cases, the most common site of extrapulmonary TB among our patients is lymph node. So that's around 35%, followed by gastrointestinal, bone and joint, pleura, CNS, and others. So mix na ito, outpatient and inpatient. So yung data namin is not unique to our hospital. This is actually the same data that is seen in the general population. The most common extrapulmonary TB is still GI-TB. Okay? I'm sorry, TB of the lymph nodes, sa general population. Okay. So, ano naman ang features of AIDS-associated tuberculosis? Usually, it's extrapulmonary and visceral lymphadenopathy. So, ibig sabihin sa loob, yung lymph node. So, sometimes they don't present with the usual cervical lymphadenopathies, but they have signs of tuberculosis. And so, what we do is we need imaging studies to actually determine if there's lymphadenopathy inside the chest or inside the abdomen. So, usually, AIDS-associated TB is also disseminated. So they just don't present with simple lang na pulmonary tuberculosis. They have pulmonary TB, they can present with CNS TB, they have visceral lymphadenopathies, they can have gastrointestinal TB. So disseminated siya. And TB among patients with HIV can also present with tissue abscesses, no? So it's common, no? I'm sure also in your hospitals, you've seen patients na merong mga abscesses na it can be subcutaneous, or some patients can present with the psoas abscesses, which is very common, no? Yung psoas abscess is usually also associated with spinal tuberculosis. TB among HIV usually progress rapidly. And these patients, no, if you do skin testing for PPD, usually negative sila, no? So ibig sabihin nun, they just don't actually, they don't have a robust, no, immune response to antigens, which is usually what we want to determine when we do a PPD skin test. Okay, so how do we diagnose TB among our patients, no? We still follow the manual of procedures of the Department of Health. Wala namang pinagkaiba, no, yung pag-diagnose natin ng TB among patients with HIV or those with unknown HIV infection or with HIV. So same lang. We still use the yung classification ng yung TB symptoms. So if a patient presents with symptoms, with the following symptoms for more than 2 weeks, no? So ito yung very prominent clinical symptoms of patients with tuberculosis: cough, unexplained fever, unexplained weight loss, and night sweat, no? So if they don't have this, no, if our patients don't have this, we usually request for a chest X-ray. Now, if the chest X-ray suggests tuberculosis, even if they are asymptomatic, we still work them up, di ba, for tuberculosis. And we actually categorize them as presumptive TB, and then we do the sputum test. Ngayon, ang problema, some of them cannot really produce sputum, no? So we'll discuss that later. But if a patient now presents with cough, unexplained fever, unexplained weight loss, and night sweats, automatically, we actually work them up for tuberculosis. And actually, more than 90% of your responses kanina sa poll, you mentioned that you actually do the testing either in your facility or you refer them to TB facility. Okay? So it's very important that we do chest X-ray for patients with HIV, even if they don't have symptoms, specifically for those newly diagnosed and still to be started on antiretroviral treatment, or they have been exposed to a TB case, no? And also, we actually advocate annual chest X-ray for our patients, no? So this is also a recommendation of the Department of Health to do annual X-ray, especially for high-risk patients, no? And our patients are considered actually high-risk, no? Kasi nga, they are immunocompromised, okay? So we do this chest X-ray as part of our screening. Okay, so later on, we will discuss about how to diagnose. But in this algorithm, please note that the test that we do already in the Philippines, hindi na siya sputum smear microscopy, no? We actually advocate use of rapid molecular TB tests like Expert MTB-RIF. And if Expert is not available in your facility, we also have other molecular tests like TB Lamp, no? But Expert is actually the platform that is widely used in the Philippines. Okay, so Expert MTB-RIF is an automated cartridge-based nucleic acid amplification test for TB. And it detects M. tuberculosis, no? But it can also detect rifampicin resistance. And it can provide results directly from pulmonary and extrapulmonary specimens. And if you have a very good laboratory, they should be able to inform you of the results of the Expert in less than 2 hours. And this is actually the preferred test for patients with HIV because it's more sensitive than smear microscopy. Okay? Ngayon, if we don't have experts, some laboratories actually have the TB lamp, TB lamp assay. So TB lamp is like expert, it's also WHO recommended. It has a moderate sensitivity and high specificity for tuberculosis. But compared to smear microscopy, mas sensitive pa rin ang TB lamp. So ano bang ibig sabihin ng TB lamp? No? TB lamp is acronym for TB loop-mediated isothermal amplification assay. It is a manual assay. It actually requires, according to the manufacturers, just less than 1 hour to perform. And it can detect MTB directly from sputum specimens. Yan yung isa pang pagkakaiba nila with expert, no? For expert, we can actually use other extrapulmonary specimens. But for TB lamp, for now, ang recommendation, ang gamit pa lang niya for sputum specimens. And it cannot detect resistance to anti-TB drugs. Unlike expert can detect resistance to rifampicin. Kaya lang, ang advantage nito over the expert platform, ang TB lamp, it does not require sophisticated instrumentation. It can be used at the peripheral health center level kasi manual yung reading, yung pagbasa kung positive or negative yung test. And it's also now available in the Philippines. Okay. So if both expert and TB lamp are not available, pwedeng mangyari pa rin yan. In the chat box, I saw some of you are from Leyte. I'm not sure if in Leyte you already have access to expert. But in some laboratories, in some health centers, without access to molecular diagnostic tests for TB, smear microscopy is still acceptable. But remember that sputum AFP requires at least 2 sputum samples to increase the diagnostic yield, hindi lang isa. Ang expert kasi tsaka TB lang, pwedeng isa lang, hindi natin kailangang 2 or 3 na sputum samples. Okay, so what's important to emphasize to our patients is that proper collections of sputum is very important para mag-increase yung yield ng test. Kasi kung yung kung saliva lang yung sinasubmit nila, the diagnostic yield of these molecular tests are also affected. So it's important to tell them how to properly collect a sputum. And this is an example of a poster that you can actually use in your centers, in your clinics, in your laboratory, to advise your patients how to properly collect sputum. Okay, so what are the challenges in the diagnosis of extrapulmonary TB? It's actually harder to diagnose EP-TB compared to PTB for the following reasons. It is less common. It's less familiar to most clinicians. The location of EP-TB usually involves inaccessible sites because of the nature of the sites involved. There are fewer bacilli, and it can cause more damage. Of course, a classic example of an EP-TB site is the meningitis, CNS, central nervous system. So patients with TB meningitis are very hard to diagnose. Sometimes invasive procedures are required to establish the diagnosis of extrapulmonary TB. So for a patient with TB meningitis, we need to do a lumbar tap, and we need to send the cerebrospinal fluid for testing. So EP-TB, as I mentioned several times already, is very common among patients with HIV. So we have to be familiar in diagnosing extrapulmonary TB cases. Later, I will see if I have time to show you examples of EP-TB. But please remember that the usual forms of EP-TB are posibacillary. Konting-konti lang yung bacilli niyan. So most of the time, negative ang sputum exam, kahit gumamit pa tayo ng expert. And bacteriologic test for TB is often negative. And I mentioned to you that sometimes the lymphadenopathy is visceral. So nandun siya sa loob, no? Nasa mediastinum, nasa retroperitoneum. So mahirap siyang ma-visualize. No? We really need to do imaging studies to actually determine the site of extrapulmonary TB. And although it's hard to get samples, we still need to really try to obtain specimens and to test them microbiologically and histologically. So as I've mentioned, there are other rapid diagnostic tests aside from expert. And of course, in case na wala pa rin talagang access to molecular tests, pwede pa rin gamitin sputum TB, but we can actually also do aspiration of abscesses. We can also do aspiration of lymph nodes. And we need to coordinate with our colleagues, mga surgeons, mga interventional radiologists, to get these samples. And we can actually test them also for TB using our molecular diagnostic test. Okay, so, okay, next. For the diagnosis of EPTB, our guidelines now recommend using still bacteriologic workup. So, because it will really help us in managing these cases. Kasi kung, for example, sa gene expert ng lymph node, lumabas na resistant sa rifampicin, then we need to refer these patients for drug-resistant TB management, na usually hindi nagagawa sa lahat ng mga treatment centers. Okay. One test that maybe we should be familiar with is the urine lateral flow lipoarabinomannan, or the LAMP assay, LF-LAMP. Yan ang acronym niya. It actually detects mycobacterial lipoarabinomannan antigen in urine of patients with advanced HIV. So we need to emphasize that, kasi hindi to recommended test for the general population, unlike expert, unlike TB LAMP. Okay, malito, yung isa TB LAMP, ito LAMP. Okay? But LAMP has been found out to be more sensitive for diagnosis of TB among PLHIV, specifically patients with lower CD4 cell count. So the sicker HIV patients, yung may AIDS, And some of these patients cannot produce sputum. Most of them have extrapulmonary tuberculosis. And they found out that urine LAMP can help diagnose TB in these cases. And I think there are already some clinics using this. And some organizations with TB projects have partnered with our treatment facilities for HIV patients. And they are already utilizing this test. Okay, so the WHO recommends the use of LF-LAMP for PLHIV in the inpatient settings. So usually the patients are the sicker patients. And also they have recommendations for the use of this test for PLHIV in the outpatient settings. And usually sila pa rin yung sicker, yung sicker na HIV patients. So when they compared kasi dun sa isang study, yung may HIV versus may HIV, ginamit nila yung LF-LAMP to diagnose TB. The sensitivity is actually very low for HIV negative, parang 20% lang. Kaya hindi siya recommended for the general population. But it increases, the sensitivity increases for very sick individuals na may HIV. I think the sensitivity is around 40% or higher. It's still a low sensitivity, as compared to expert. Yung expert, ang sensitivity niya sa TB testing, umaakyat yan up to 96%. But yun nga, we have HIV patients with extrapulmonary TB and they cannot produce a good specimen, or the specimens are inaccessible and we need invasive diagnostic test to get samples. So urine kasi, it's not invasive, di ba, to get a sample. Urine, pakolek mo lang yung patient ng urine and then you can use this test. Okay, so it's also important for us in the clinic to interpret, to know how to interpret our molecular diagnostic test. So since expert is the most common molecular diagnostic test for TB in the Philippines, I'm sure that we will encounter receiving expert tests for patients, and we should know how to interpret. So in the national um, TB program manual of procedures, and this is the latest MOP so far, merong table na ganito. So maganda actually siyang guide. So if your expert MTB result shows MTB detected, rifampicin resistance is not detected, then you can treat the patient as a drug susceptible TB case. Okay, so ang drug susceptible, ibig sabihin yan, you can still use your HRCE regimen. Okay, now if the result is MTB detected, RIF resistance detected, then you have to determine if your patient is a high risk for drug resistance or a low risk for drug resistance. But please remember that HIV cases are already considered as high risk for drug-resistant tuberculosis. So usually, if your patient is HIV positive and the expert result shows this, MTB detected, RIF resistance detected, they should already be referred to a PMDT facility or Programmatic Management for Drug-Resistant TB facility for MDR-TB treatment. Okay? And then, meron namang cases in the general population that are low risk for drug-resistant TB. So what they do in the clinics is to repeat the expert and to actually follow the result of the second test. But usually hindi naman common yan. This is not a common scenario. Number 3, ito, mas common pa siguro yan. MTB detected, RIF resistance indeterminate. So the DOH actually recommends collecting another specimen, a good specimen, make sure it's a good specimen, and repeating the test, and to follow the result of the second test. But you still need to make sure that your patients are properly monitored kasi baka pala resistant yung mga yan, and then sometimes natitreat sila as drug susceptible. Pag yung second test lumabas na susceptible yung result. Okay? And pag invalid yung result ng expert, you repeat. Okay? Now, if MTB is not detected, you have to properly reassess your patients, no? Yun nga, you still do X-ray for screening, and then patients with X-ray positive results, no? And even with an expert negative result. So mga patients na may extrapulmonary TB, pwedeng X-ray normal, no? They can still be empirically treated, no? For TB. Yan ang tinatawag na clinically diagnosed. Kung nag-positive kasi yung expert, yung smear microscopy, kung nag-positive yung LAMP, ang tawag dyan bacteriologically confirmed. No? Pero kung wala kang evidence of bacteriologic confirmation but you opt to treat anyway for TB, that case is clinically diagnosed. Okay? So, that DOH also provides algorithm for classifying a TB case. Okay, so this is very important, no? We should classify them based on bacteriologic confirmation. And I've mentioned earlier, we can confirm bacteriologically through these tests. Pero kung negative yung mga tests na yan, but you still highly suspect TB based on clinical signs and symptoms, X-ray, or histology, by biopsy, or other imaging tests like CT scan, ultrasound, then it's really up to you, if you want to treat the patient for TB. So ang tawag dyan ay clinically diagnosed TB. Okay? And we've discussed extensively, the anatomical sites involved. It can be pulmonary, it can be extrapulmonary. And then the history of TB treatment. Your case can be a new case or a retreatment case. And of course, it's very important. Since we already use expert, in many sites, many areas in the country for TB diagnosis, we can actually determine the drug resistance pattern. So we can have cases with drug susceptible TB, no resistance to any of the anti-TB drugs. We can actually have just isoniazid resistant TB. We can have RIF resistant TB or MDR TB, which is resistance to isoniazid and rifampicin. That's the definition for MDR-TB. resistance to the two most important anti-TB drugs, isoniazid and rifampicin. And then meron tayong mga tinatawag natin na pre-XDR. So, ang pre-XDR ay pre-extensive drug resistance, no? So, ito yung hindi nakaka-fulfill ng criteria ng XDR-TB. So, you see XDR-TB is extensive drug-resistant TB, and it's resistant to isoniazid, to rifampicin, to the fluoroquinolones, like levofloxacin, moxifloxacin, and the second-line injectable drugs like amikacin, capreomycin. Okay? And we have all these cases now in the Philippines. Okay, so if you encounter a TB case in your facility, you should be able to classify now in your diagnosis whether it's pulmonary or extrapulmonary, whether it's bacteriologically confirmed or clinically diagnosed, whether it's pulmonary, extrapulmonary, whether it's a new or a retreatment case, and any available drug resistance pattern. Okay, so example of a TB diagnosis, no? Dan dapat nakikita natin sa chart nyo. Ilalagay nyo yan. TB, no? Bacteriologically confirmed pulmonary TB, new, no rifampin resistance. Or clinically diagnosed gastrointestinal TB, extrapulmonary TB, new case. Bacteriologically confirmed POTS disease, L2, L4, extrapulmonary TB, retreatment case with rifampicin resistance. No? So it's actually important, no, that you learn how to completely diagnose the case. No? So for reporting for procedures and also for case management. Okay, TB treatment. According to the poll earlier, no, yung sa participants today, most of you treat your patients, and most of you are actually comfortable treating patients with HIV and with TB. So the DOH MOP details the recommended treatment for PTB and EPTB. So the recommended anti-TB regimen for bacteriologically confirmed or clinically diagnosed TB is still 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid and rifampicin in the continuation phase. So the 2 months is the intensive phase, and the 4 months HR is the continuation phase. For EPTB of the CNS, bones and joints, the continuation phase is usually extended to at least 10 months. So for a total of 12 months of TB treatment. So if expert testing cannot be performed for EPTB cases, empiric treatment usually still utilizes this regimen. And it can still follow the 6-month or longer treatment duration depending on your diagnosis. So please remember that fixed dose combination TB drugs, no, are preferred over single drug formulations to simplify treatment and also to improve compliance of patients to the treatment regimen. So the first-line anti-TB drugs are still isoniazid, rifampicin, PCA, and ethambutol. And the most effective, no, anti-TB meds are isoniazid and rifampicin, and you should try to include these two drugs, no, when you treat your patients with tuberculosis. So please be also aware of the side effects. Most of the anti-TB drugs, no, affect the liver. Kaya nga ano sila tawag sa kanila ay hepatotoxic, no. So you have to monitor your patients, no, during treatment, especially HIV patients, kasi ang dami-dami nilang gamot, ang dami-dami nilang OI, sabay-sabay yung mga gamot na binibigay sa kanila. So it's very important when you treat TB for these patients, no, you monitor the adverse effects and you have to intervene immediately. Kasi sometimes pag hindi tayo nakaka-intervene kaagad, no, they stop treatment, and we don't want them to stop TB treatment kasi magiging mas complicated na yung TB nila if we don't treat them properly. Okay? So, for the doses of the anti-TB drugs, no, we still use the usual na dosing regimen per kilogram. No? I think it's important that we also remember, no, yung maximum dose for isoniazid, for rifampicin, for PZA, ethambutol. No? And if it's fixed dose combination kasi, di ba per weight na yan? No? Weight pat. Pag nasa MOP ka, you look at the recommended dose, makikita mo yung depende sa weight ng pasyente mo. Okay. So, kung ang weight ng pasyente mo ay 55 to 70 kilograms, you can give 4 tablets, no, of your fixed dose combination anti-TB drugs. So, please remember na hindi yan ini-split. So, may mga patients pa rin kami, nakikita namin na 1 tablet fixed dose combination na anti-TB drug 3 times a day. No, these doses are for once a day dosing. So do not tell them to take 1 tablet in the morning, 1 tablet lunchtime, 1 tablet ng gabi. They should take the medicines ideally before a meal, 30 minutes before a meal or 2 hours after a meal. Mas maganda kasi yung absorption ng drug on an empty stomach. They should not split the tablets unless yung pasyente natin hindi makalunok, naka-NGT. Pwede naman yan i-crush, no? But also try to coordinate with your pharmacist, no? Kung alin yung paano to gagawin, no? And then you probably can advise the caregivers of the patients. Okay? So importante yan yung they should not take it 1 tab ng fixed dose combination 3 times a day. Kasi meron pa rin kaming patients na nakikita ganyan. Okay, so I think I've emphasized this already, that you can actually start empiric TB treatment, especially for TB patients, because a lot of them have extrapulmonary tuberculosis and hard to really confirm by bacteriological tests, if they have tuberculosis. Because if we don't treat them, the mortality is very high, for patients with TB na HIV positive, especially kung meron na silang AIDS, or mababa, sobra yung kanilang CD4 count. Okay? If you delay the treatment, then the patient can actually have more severe forms of TB and it will be harder for us to treat them. Okay, other treatment considerations, you provide vitamin B6 as an added medicine to prevent isoniazid-associated peripheral neuropathy. You can consider giving corticosteroids for TB meningitis and TB pericarditis, but not for other forms of TB, because we still don't have enough evidence enough evidence to inform us on the use of corticosteroids, for example, for other forms of extrapulmonary TB. So for TB adenitis, we don't use steroids. Okay. I think, okay. So this is also important to remember when to start antiretroviral treatment. Pag mas sick yung patient ninyo, pag mas mababa ang CD4 count, dapat mas earlier yung pag-start nyo ng anti-TB treatment. Within 2 weeks, after initiation of, baliktad, starting ART for patients on TB treatment. Okay, so uunahin lagi natin yung paggamot ng TB. Pero kung ang pasyente natin ay may AIDS, let's say less than 50 cells ang kanyang CD4 count, we should start ART within 2 weeks after initiation of TB treatment. Pag medyo mas mataas ng konti yung kanyang CD4 count, you can probably wait within 8 weeks after initiation of TB treatment before you start your antiretroviral treatment. Pero remember, yung sa TB meningitis, kailangan makontrol talaga yung CNS TB muna. So after 8 weeks talaga, before you can start your antiretroviral treatment. Kasi pag nagkaroon siya ng iris at may TB meningitis siya, medyo mas mahirap yun. Baka kailangan ma-admit siya ulit for management of increased intracranial pressure. Okay? So other important interventions, you should screen TB patients, not only for HIV, but also for diabetes mellitus. So kahit positive yung HIV niya, don't think na yan lang ang comorbids niya. Kasi mataas din ang diabetes mellitus sa Philippines. So you should screen them also for DM. You should check and control these comorbidities, especially HIV and diabetes mellitus. Because if we are unable to control HIV and DM, then we will not be able to properly manage the tuberculosis. And we should always remember that the test, no, yung expert, the TB medications, no, these are all provided for free, no, to Filipinos and even to foreigners sa local health centers natin. And the good thing is, the local health centers kasi they have mga volunteers, no, and they can monitor treatment adherence of our patients. It's very important to educate our patients regarding side effects, what to watch out for, when to consult us, no? When they are on TB treatment and also on other medications for HIV and opportunistic infections. It's very important to manage adverse reactions rapidly, immediately, effectively, not correctly. Kasi sometimes patients will just give up if they're taking too many medications and their adverse drug reactions are not properly managed. It's also important to do contact tracing among the household members, because if we're just treating the patient and we're not treating the source in the household, then our patient will still be susceptible to getting reinfected with TB. Okay, monitoring of treatment response, clinical evaluation is the most important. Resolution of fever, improvement in the appetite, weight gain, no? Meron kaming paper dyan. Weight gain is very important. Pag nag-increase ang weight ng patient, usually nag-improve din ang TB niya. So it's very easy to monitor, no? Every time your patient goes to your clinic for follow-up, you check the weight, okay? And of course, for patients with extrapulmonary TB, important yung pain. So pag nag-decrease na yung pain nila during treatment, it means that they're responding to treatment. And some draining sinuses, no, especially pag may POTS disease, TB adenitis, nag-improve yan. So yung mga wounds nila, mga draining sinuses, nagko-close, no? And sometimes we probably also can check the inflammatory markers like ESR. So this is what we use for POTS disease, no? Yung mga bone joint infections, we check the ESR, no? Pero kung limited naman yung resources ng patients, no, we really don't need to do that. We can just monitor clinically. And sometimes we also need imaging techniques to determine if they are improving, especially pag wala tayong masyadong improvement, no, sa clinical evaluation natin. So we can actually repeat, no, mga imaging tests like CT scan or ultrasound. Okay, if there's inadequate treatment response, then you suspect failure of treatment. So you might have to check again for TB bacteriologically through expert or through culture, no? Or you have to repeat imaging studies. So if there's no improvement of clinical symptoms, persistence or reappearance of sinus tracts and ulcers, then you suspect treatment failure. It can be due to drug resistance, persistent immunodeficiency, yun pala, resistant siya sa sa ARVs na binibigay natin. Or sometimes, of course, you also consider paradoxical worsening, like immune reconstitution, yung tinatawag natin na IRIS, if we treat patients with TB with antiretroviral treatment. So you don't stop anti-TB treatment. No, you don't stop also your anti-TB drugs, no, when you have immune reconstitution. You just need to support the patient, no, throughout the process para ma-reassure mo lang siya na, magre-resolve din yan. Okay, so promptly address inadequate response and you refer to an ID specialist, no, if drug resistance is suspected. We are always happy to help you. Okay, outcome. Yung outcome based on the manual of procedures are the following, no? Cured, treatment completed, treatment failed, hopefully hindi naman died. Some patients are lost to follow-up, no, not evaluated. TB is a reportable disease, and we should all be familiar with determining treatment outcomes of our patients. Since a lot of our patients, no, wala tayong bacteriologic confirmation, especially extrapulmonary TB, most of the time yung outcome natin ay treatment complete, but it still needs to be reported, no? So as I mentioned earlier, TB is a reportable disease in the Philippines. All TB practitioners should be familiar with the reporting procedures, no? And we actually have mga websites, no? May app na nga yata silang introduced, no? I think this month. And and we should all remember, no, that we should report kahit na nasa outpatient clinic ka in a private facility, you should still report your TB case to the Department of Health. Okay, Radnir, before I end, may time pa ba ako? Or open forum na tayo?
You still have 4 minutes po.
4 minutes, okay. Would you like us to go through the answers to the questions? O hindi? Ay,
No need na po.
ay, oo nga pala. Kasi may post-test, no? Sorry. Anyway, so for extrapulmonary TB, I just want to show you a few more slides, no? Disseminated TB is also miliary tuberculosis. And it usually occurs in patients with AIDS because they cannot really mount adequate immune host defenses, no, to contain the TB infection. And the mortality rate is very high. Up to 30% can die of miliary tuberculosis kasi multi-organ yung involvement. So ito, no, ito CT scan. On X-ray, sometimes we see this, no, babasahin pa nga nila normal yan eh. Pero iba siya, parang meron siyang mga maliliit na nodules. If you do a scan, no, mas magandang tignan. So you can see all of these small nodules scattered all over, no, sa lungs. So ang dissemination na yan ay hematogenous, no, sa bloodstream yan. So if you do sputum exam, negative pa rin minsan yung expert nila. Kasi wala naman siya doon sa airway, nasa blood, no? So ito is an example also of TB sa liver, no? And sometimes if your radiologist is very observant, no, kahit maliliit yung lesions, babasahin nila yan na miliary lesion. Okay? CNS TB is also one of the mga deadliest na TB outside the lungs with a mortality rate of up to 70%. And among HIV patients, the mortality rate can even be higher, no? And even if they survive the infection, there's usually neurologic sequelae, no? And we need to do imaging studies really to determine CNS tuberculosis like this, no? CT scan and MRI, no? So this is miliary tuberculosis, and this is TB, another imaging of TB meningitis. Okay. We have to do lumbar tap, no, to test for TB meningitis. So you have to refer to someone who knows how to do a tap, no. In Metro Manila, we usually refer to a neurologist. In some sites outside Metro Manila, I know that general practitioners can also do this. And we can send the specimen for expert, okay? Expert na ngayon ang test of the recommended test for CNS TB because it has a faster turnaround time. Okay? And TB naman, TB effusion or TB pleurisy. Pleural effusion due to tuberculosis is also very common among patients with HIV. When you do an expert, no, on the fluid, usually negative yan. No? And it can present on X-ray. No? When you do an ultrasound, you can actually determine the amount of pleural fluid. And even without an ultrasound, before we usually do a tap. Pero for safer sa patient, of course, is to do it ultrasound guided. Okay, and that's how we do it. No? We insert a needle to drain the fluid, no, from the lung, and then we test. And then based on the result of the pleural fluid studies, no, we can determine if it's most likely TB. No? Dati nung wala pang expert, we just depend on the cell count, diff count, no? And then ngayon may expert na, so we actually do expert also. Okay, lymph node TB, it's the most common form of EPTB. Usually wala ding pulmonary tuberculosis pag EPTB ng lymph nodes. Negative din yung sputum niya, no? But usually ganyan. And patients of course don't like it, no, because it's very visible nasa neck. Among our patients with HIV, meron ding malalaking lymph nodes, no? But it's not actually TB. No? If you give them ART, lumiliit yung lymph nodes. But if you are treating ART and lumalaki yung lymph nodes, you should suspect na baka TB adenitis din yan. And you should do an imaging study, you get a sample, you send it for expert, and usually positive yan for TB. Okay? Spinal TB is very common still in the Philippines, no? Ito medyo late stage na yan kasi meron na siyang gibbous, no? May deformity na siya sa spine. And what we do, we can also do imaging If we see accumulation of pus near the spinal cord, we also stick in a needle there, either CT scan or ultrasound guided, no? Depende kung ano yung available sa site ninyo. Get samples, send it for expert testing, usually positive din yan for TB. Okay, that's how we do it, no? We aspirate the fluid. Okay, last na pala yun. So Radnir, that's my last slide for extrapulmonary TB. And thank you for giving me extra time to show my
Okay.